Welcome to the deep dive. If you ever waded through dense medical texts trying to pinpoint that key piece of information, think of this as your shortcut. Today, our mission for you, the learner listening in, is a really focused exploration of drug-induced lupus erythematosus DILE for short.
Right. We're diving into autoimmunity, but with a very specific and honestly kind of a strange angle. We're looking at when a prescribed medicine actually causes the immune system to turn on the body in a way that looks a lot like systemic lupus or SLE.
Exactly. We're using your expert pathology sources to cut through the complexity and figure out, what is DLE, how is it different from classic SLE, and really what's going wrong biochemically that lets a drug become this kind of environmental trigger.
Okay, so the simplest way to put it is that DILE is an SLE-like syndrome. It really only pops up in patients taking certain specific drugs. And crucially, it tends to go away once you stop taking that drug. It's almost like a neat little experiment showing how an external factor can break that self-tolerance we normally have.
Okay, but the second you say SLE-like, my mind immediately goes to, and I know this is what you, the learner, need to grasp, how similar are we talking? Is it the same kind of potential for, well, widespread damage across multiple organs?
That's the million-dollar question, isn't it? And we can't really answer that fully until we look at the actual drugs involved. DILE is very much linked to specific medications, and the type of drug often gives us clues about what kind of reaction we might see.
Right, let's start there then. The source material we have lists several well-known drugs that have this, well, pretty surprising side effect. Can you run through those examples for us? What connects them to this specific immune pathway?
Sure. Historically, the big ones often cited in the sources are drugs like hydralazine, that's a blood pressure medication, and procainamide, which is used for heart rhythm problems. Then you've also got others like isoniazid, an antibiotic, and D-penicillamine.
And it's not just that they happen to be associated, right? The sources seem to suggest it's how these older drugs are processed, metabolized by the body.
Precisely. Take procainamide, for instance. It's generally thought that it's not the drug itself, but one of its breakdown products, its metabolite, N-acetylprocainamide. This metabolite seems to be able to chemically latch onto proteins that are naturally in our body, like, say, the histone proteins we'll definitely talk more about. It changes their structure just enough that the immune system suddenly sees them as foreign, as something to attack.
Ah, okay, so it's less like a general alarm bell ringing for inflammation and more like a very specific molecular tweak creating this kind of altered self that the body then targets by mistake.
Exactly right. But what's really interesting, and maybe a bit unsettling, is that this isn't just a problem with older drugs. The material points out that even some very modern, sophisticated biologic therapies can trigger DIE.
You mean the anti-TNF therapies? That seems like the ultimate irony, doesn't it? I mean, these drugs are specifically designed to dampen down autoimmune inflammation in conditions like rheumatoid arthritis, but they themselves can sometimes kick off an SLE-like response.
It really underscores how tricky immune regulation is. Anti-TNF drugs work by blocking tumor necrosis factor, which is a major player in inflammation. But when you block TNF, you're tilting the whole immune balance. You might inadvertently boost certain B-cell activities or change the mix of regulatory T cells, and that shift can sometimes mess with the B-cell's tolerance mechanisms, making them start producing these autoantibodies.
It's like a delicate balancing act. You push down here, and something else might pop up over there. Okay, so let's shift from the why to the what happens next. The sources are pretty clear that just being on one of these drugs doesn't automatically mean you'll get sick.
That's a really defining aspect of DLE pathology, actually. A lot of patients will develop the autoantibodies, these ANAs we mentioned, but for many, their immune system kind of keeps things in check. They stay completely symptom-free, even with the antibodies present.
How big is that gap between having the antibodies and actually getting sick? Can you give us the numbers from the sources?
Oh, it's huge. The material uses procainamide again as a classic example. Something like 80% of patients taking it will test positive for anti-nuclear antibodies, ANAs, usually within about a year. But, and this is the key part, if you follow that 80%, maybe only about a third of them will ever actually show clinical symptoms of DILE.
Wow. Okay, that brings up a really important practical point then for diagnosis and treatment. Why don't doctors just treat everyone who tests positive for ANAs on these drugs? If 80% have the antibodies, but more than half of that group never feel sick, what's holding the disease back? Why are those immune tolerance mechanisms still working for them?
That really gets to the heart of what we call peripheral tolerance. It's still a bit of a mystery, honestly. But for most of those individuals, yes, their immune system is making the antibodies, but it's not escalating. It doesn't progress to activating the P cells in a big way or causing those massive cytokine releases or the widespread immune complex deposits that do so much damage in classic SLE. They're sort of immune firewall holds.
So when that firewall does get breached, when the disease actually manifests clinically, what does that look like for the patient? Is it that severe multi-system attack that makes classic SLE so, frankly, frightening?
Thankfully, no. And this is probably the most important distinction in clinical practice. Generally speaking, the symptoms of DIE are milder. They're often characterized by what we call constitutional symptoms, things like arthralgias, which is just severe joint pain, maybe a fever, and serositis.
Serositis, that's inflammation of those thin membranes lining body cavities, like around the lungs, the pleura, or the pericardium around the heart.
Exactly. It can definitely be painful, make you feel quite unwell, and it needs treatment, but it's typically not life-threatening in the way severe SLE can be. The absolute crucial piece of information here for you, the learner, is comparing it directly to classic SLE.
And the big difference is
DILE very rarely involves the organs where SLE often does the most damage. Kidney involvement, renal problems, and central nervous system, or CNS involvement, are distinctly uncommon in DILE. That's the major separation from classic SLE, where kidney disease, nephritis, is often the biggest driver of long-term problems and even mortality. You could say DILE tends to be more about joints and membranes, while SLE is truly systemic and can hit those vital organs hard.
okay, that makes sense. So if the symptoms are so different in severity and location, the autoantibodies driving them must be different too, right? We know in classic SLE, those immune complexes, often involving antibodies against double-stranded DNA, are what gum up the works in places like the kidneys.
You've nailed it. That's absolutely the key difference. And it's how we often distinguish them in the lab. We rely heavily on that serologic fingerprint. In classic SLE, antibodies specifically targeting double-stranded DNA, anti-dsDNA, are very common and seem to be major drivers of the disease, especially kidney problems.
But in DILE,
In DILE, anti-dsDNA antibodies are rare. Instead, what you see is an extremely high frequency of antibodies aimed at histones.
histones, those are the proteins that DNA wraps around inside the cell nucleus, like a spool for thread.
Precisely. They form the core of the nucleosome structure, and this specific antihistone antibody profile, that's the immunological signature that strongly suggests DILE rather than classic SLE.
Okay, but that begs the question, based on our material, why histones specifically? Why would a drug like procainamide or hydralazine provoke an attack against the protein spool instead of the DNA thread itself?
It likely comes down to how the body deals with cells that die. Normally, cells undergo programmed death, apoptosis, and they get cleaned up really quickly and efficiently by specialized cells, macrophages. If that cleanup process is slow or inefficient, the contents of the dying cell, including those nuclear components like histones, can spill out and linger.
And you're saying certain drug metabolites might make this worse or interfere somehow?
Yes, that seems to be part of the picture. Drugs like procainamide, or even things like UV light exposure in SLE, might disrupt how these dying cells are normally processed. On top of that, remember how we said the drug metabolites can bind to proteins? Well, they seem to bind particularly well to these histone proteins, altering their shape. So now you've got two problems. These altered histones are exposed because cleanup is slow, and they look different because they've got a drug molecule stuck to them. They basically send out danger signals to the immune system.
Got it. So the immune system is reacting primarily to this very specific target, the altered histone protein it finds lying around, rather than the massive amount of DNA containing immune complexes that cause so much trouble in classic SLE.
Exactly. And it's thought that because these DILE immune complexes are mainly histone-based, they behave differently. They might be less likely to deposit in critical places like the tiny blood vessels in the kidneys. This difference in the type of immune complex probably explains why the disease course is generally much milder. The specific mechanism really shapes the outcome.
Let's just quickly circle back to those anti-TNF drugs now that we have a clearer picture of the mechanism. We said they cause DILE despite reducing inflammation. Does the material indicate if they also tend to induce these antihistone antibodies?
Yes, they absolutely can. Although the antibody profile in anti-TNF induced lupus can sometimes be a little more varied than what you see with, say, procainamide. But the core features are often still there. development of ANAs, and frequently a high level of antihistone antibodies. The thinking is that by blocking TNF, you're creating this kind of immunological imbalance that allows B cells, the antibody producers, to sort of escape their normal checks and balances. They start making these perhaps lower affinity autoantibodies against nuclear material that gets exposed.
So the takeaway message is the immune system is this incredibly intricate network. Trying to adjust one part, even with good intentions, can have unexpected ripple effects somewhere else.
Absolutely. And what's really quite fascinating is how studying DILE actually helps us understand classic SLE better, too. It reinforces the idea that the severity of autoimmune disease isn't just about whether you have autoantibodies, but critically, which specific autoantibodies you have and what they do in terms of forming and depositing those immune complexes.
Okay, let's try to wrap this up for the learner.
Yeah.
What's the essential, maybe three-point summary of drug-induced lupus erythematosus that really defines it?
Right. So first, DILE is a distinct clinical issue. It's an SLE-like syndrome, but the key is that it's triggered by specific medications, often ones used for heart conditions or paradoxically other autoimmune diseases. Second, and this is crucial for patients, it generally follows a milder course than classic SLE. Why? Because those really vital organ systems, the kidneys and the central nervous system, are usually spared. That's the main difference in impact.
And that milder, often reversible nature is backed up by the third point. The lab tests, the diagnostic fingerprint.
Exactly. The diagnosis really leans on the serology. You typically find a high frequency of those antihistone antibodies, while the anti-dsDNA antibodies, the hallmark of severe SLE, are usually rare or absent.
And, critically, the outcome is generally predictable, right? Stopping the drug usually leads to improvement, often within weeks or months. Knowing about this specific condition allows for a quicker diagnosis, better management, and importantly, helps avoid unnecessarily harsh treatments. It makes you think, though, this whole connection between drugs, inflammation, how cells die and get cleaned up, it makes you wonder if these processes can expose nuclear antigens and lead to autoantibodies. How many other chronic conditions out there, maybe ones we don't even think of as autoimmune yet, might be linked to subtle glitches in our body's waste disposal systems? Problems clearing out those apoptotic cells that we just haven't fully pieced together yet. Definitely something for you to keep thinking about as you continue your learning journey.